Hi, my name is Dr. Hussein Hadi from the Department of Pathology and Forensic Medicine at Mustansariya University. In this talk, the pathology of endocrine system will be outlined, in particular from its practical point of view. Accordingly, the causes, morphology, and clinical presentations of different endocrine diseases will be addressed herein. The endocrine system is contained of a widely distributed group of organs, including pituitary, thyroid, parathyroid, and adrenal glands. These organs work together to maintain the body's metabolic equilibrium or homeostasis. The cells of the endocrine system achieve this by secreting molecules called hormones. The hormones can be classified into hormones that act by binding to cell surface receptors, which is composed of first peptide hormones such as growth hormone and insulin, and secondly is the small molecules such as epinephrine. We should know that binding of these hormones to cell surface receptors leads to an increase in intracellular secondary messenger such as cyclic AMP, inositol triphosphate, and ionized calcium, and can activate intracellular signaling pathways that may stimulate cell growth or differentiation or alter cell function. The other is the hormone that act by binding to intracellular receptors. The resulting hormone receptor complex bind to specifically to regulatory elements in DNA, thereby activating the expression of specific target genes. Hormones of this type include steroids, for example estrogen and progesterone, and glucocorticoids. The other is the retinoids, for example vitamin A, and as well as the thyroxine. To begin with, the pituitary glands will be the first organ to discuss from the practical aspect. The pituitary gland has a central role in the regulation of most of the other endocrine glands. It is a small bean-shaped structure that lies at the base of the brain. The normal gross appearance of the pituitary gland removed from the sella turcica is shown here in this figure. The larger portion, the anterior pituitary, called the adenohypophysis, appears in these images toward the top of the gland, indicated by the upper triangle. The image at the left shows diamond-shaped, which is the stalk coming from the hypophysis entering the pituitary glands. The posterior pituitary, which is the neurohypophysis, is the smaller portion of the gland at the bottom of each image, indicated by lower triangle. The adenohypophysis has a dual blood supply with a hypophyseal portal system and small perforating arteries. We should know that the diseases of the pituitary accordingly can be divided into those that primarily affect the anterior or posterior lobes. The normal microscopic appearance of the pituitary gland is shown here in this image. The highly vascularized adenohypophysis is at the right of the field, and the neurohypophysis is at the left, which resembles neural tissue because it is composed of modified glial cells along with the axons of hypothalamic nerve cell bodies. The neurohypophyseal hormones, including the oxytocin and vasopressin, which is also called antidiuretic hormone, are synthesized in the hypothalamus and transported along axons to the neurohypophysis, from which they are released into the bloodstream and carried systemically to act on cells in target organs. At higher magnification, the normal pituitary microscopic appearance of the adenohypophysis is shown here in this image. The adenohypophysis contains three major cell types, and these are the pseudophils, basophils, and chromophobes. The staining is variable, and to properly identify specific hormone secretion, immunohistochemical staining is necessary. A simplistic classification is as follows. The pink acidophils, which is indicated by a red triangle, secrete growth hormone, somatotrophs, and the prolactin, the lactotrophs. Moreover, the dark purple basophils, shown as a blue triangle, secrete ACTH, the corticotrophs, the thyroid-stimulating hormone, thyrotrophs, and follicle-stimulating hormone, luteinizing hormone, the gonadotrophs. The pale staining chromophobes, shown as a yellow triangle, have a few cytoplasmic granules but may have secretory activity. As in all endocrine glands, there is a prominent vascularity with many capillaries into which the hormones are secreted for distribution throughout the body. The secretions of these cells are under control of hypothalamic releasing factors, which are all positive, acting except for dopamine, which inhibits lactotrophs. The signs and symptoms of pituitary disease fall into the following categories. First is the hyperpituitarism-related effects. Hyperpituitarism arises from excessive secretion of trophic hormones. It most often results from an anterior pituitary adenoma. Secondly is called the hypopituitarism-related effects. Hypopituitarism is caused by deficiency of trophic hormones and results from a variety of destructive processes that may damage the pituitary, including ischemic injury, surgery, radiation, and inflammatory reactions. The other is the local mass effects. Among the earliest changes associated with pituitary neoplasms are radiographic abnormalities of the sella torsica, including cellular expansion, bony erosion, and disruption of the diaphragm cilia. As shown in this figure, the circumscribed mass lesion present here in the sella torsica is a pituitary adenoma. The MRI and the diagram, this T1 weighted MRI image in axial view shows a bright pituitary macroadenoma indicated by red triangle. Macroadenomas, by their size, can erode the sella torsica to produce headaches and impinge on the optic chiasma. The optic chiasma is the area where the optic nerves from the right and left eyes cross near the pituitary gland. Lesions of the optic chiasma produce visual field defects, most commonly bitemporal hemianopia, as shown by the diagram. Bitemporal hemianopia is a medical description of a type of partial blindness where vision is missing in the outer half of both the right and left visual field. Consequently, though pituitary adenomas are benign, they can produce problems either from a mass effect or from production of hormones, such as prolactin or ACTH. It is worth to know that the most common cause of hyperpituitarism is a hormone-producing adenoma arising in the anterior lobe. Less common causes include hyperplasia and carcinomas of the anterior pituitary, secretion of the hormones by some extrapituitary tumors, and certain hypothalamic disorders. Some salient features of pituitary adenomas are as follows. First, pituitary adenomas are classified on the basis of hormones produced by the neoplastic cells, which are detected by immunohistochemical staining performed on tissue sections. These are lactotroph, somatotroph, mammosomatotrophs, corticotroph, thyrotroph, and gonadotroph adenomas. Secondly is that the pituitary adenomas can be functional or non-functioning, which means not producing hormone, or even silent, that means demonstration of hormone production at tissue level only, without clinical manifestations of hormone excess. The other is that the pituitary adenomas are designated as microadenomas if they are less than 1 centimeter and macroadenomas if they are greater than 1 centimeter. Next is that the non-functioning adenomas are likely to come to clinical attention at a later stage. Because of their larger size, non-functioning adenomas may intrude upon and destroy adjacent anterior pituitary adenoma, leading to hypopituitarism. We should know that the mutation of the genus gene, which results in constitutive activation of a stimulatory G protein, is one of the more common genetic alterations. Herein is a high-power microscopic view of an adenohypophyseal adenoma. Note the monotonous appearance of these small round cells, and this is the cellular monomorphism. You could also note the absence of reticulin network. Functioning adenomas are associated with distinct endocrine signs and symptoms. Other endocrine system disorder that tries to cover in this presentation is the thyroid dysfunctions, includes hyper and hypothyroidism, autoimmune thyroid diseases, diffuse and multinodular goiter, as well as thyroid neoplasms. This is the normal appearance of the thyroid gland on the anterior trachea of the neck. The thyroid gland has a right lobe and left lobe indicated by the yellow triangles, connected by a narrow isthmus. It normally has a reddish-brown, firm appearance and is difficult to palpate on physical examination. The normal adult thyroid gland weighs 10 to 30 grams. The thyroid in embryogenesis is derived from an evagination from the foramen cecum of the tongue that migrates downward along the thyroglossal duct to a position over the thyroid cartilage in the anterior neck. The thyroid produces the thyroid hormones, mainly the T3 and the T4. A small amount of dietary iodine is required for thyroid hormone synthesis. In the past, many cases of adult goiter with the myxoedema were caused by diet lacking in iodine, whereas in infants and children this manifested as cretinism. Mostly T4 is released, but peripherally T4 is deiodinated within cells to the more biological active T3. T3 and T4 increase the basal metabolic rate, including anabolic and catabolic processes. Normal thyroid seen microscopically consists of round follicles lined by a cuboidal epithelium, which is indicated by a yellow triangle. and filled with pink homogeneous colloid. The follicles vary somewhat in size. The colloid storage product containing thyroglobulin that is metabolized to release thyroid hormones, mainly the T4 and T3, under the influence of TSH released from the anterior pituitary thyrotropes, which sense levels of circulating thyroid hormone. Thyroid hormone acts on nuclear thyroid hormone receptor in target cells to upregulate transcription of proteins that drive carbohydrate and lipid metabolism while stimulating protein synthesis. Thyrotoxicosis is a hypermetabolic state caused by elevated circulating levels of free T3 and T4. Because it is caused most commonly by hyperfunction of the thyroid gland, it is often referred to as hyperthyroidism. However, in certain conditions, the oversupply is related either to excessive release of performed thyroid hormone, for example in thyroiditis, or to an extrathyroidal source rather than to hyperfunction of the gland. We should know that the three most common causes of thyrotoxicosis are associated with hyperfunction of the gland and include the following. First, diffuse hyperplasia of the thyroid associated with the Graves' disease, which account for approximately 85% of cases. The second cause is the hyperfunctional multinodular goiter, and the other is the hyperfunctional thyroid adenoma. The clinical manifestations of thyrotoxicosis are variable and are attributed to hypermetabolic state and overactivity of the sympathetic nervous system, which include the constitutional symptoms at which the skin tends to be soft, warm, and flushed. In addition, heat intolerance and excessive sweating are common. Moreover, weight loss, despite increased appetite, could occur. Regarding the GIT, fat malabsorption and dysphoria could develop. The cardiac manifestation is the palpitations and tachycardia are common. For the neuromuscular effect, there could be nervousness, tremor, and irritability resulting from sympathetic overactivity, and nearly 50% develop proximal muscle weakness, which is the thyroid myopathy. The most important is the ocular changes, often called attention to hyperthyroidism, at which the patient could develop a wide staring gaze and lid lag are present because of the sympathetic overstimulation of the superior tarsal muscle, which functions alongside the levator palpebrae superioris muscle to raise the upper eyelid. However, full-blown thyroid ophthalmopathy associated with proptosis is a feature seen only in Graves' disease. Accordingly, this figure shows the patient with hyperthyroidism, and you could notice a wide-eyed staring gaze caused by overactivity of the sympathetic nervous system, which is one of the features of this disorder. The other thyroid disorders are called autoimmune thyroid disease. These disorders include thyroiditis with some form of thyroid inflammation, as well as antibody-mediated disturbances in thyroid function that are not necessarily associated with inflammation, exemplified by Graves' disease. Thyroiditis clinically significant subtypes are: first, Hashimoto-thyroiditis; secondly is the granulomatous decurvens thyroiditis; and finally the subacute lymphocytic thyroiditis. The chronic lymphocytic thyroiditis, which is also called the Hashimoto thyroiditis, it is the most common cause of hypothyroidism in areas of the world where iodine levels are sufficient. It is characterized by gradual thyroid failure secondary to autoimmune destruction of the thyroid gland. In addition, we should know that the age is mostly between 45 to 65 years and is more common in women. According to this figure, this is symmetrical small thyroid gland demonstrating atrophy. This is the Hashimoto thyroiditis. Grossly, there is a relentless destruction of the thyroid follicles over the years with eventual atrophy, so that the thyroid is often not palpable when a patient presents with myxedema from the hypothyroidism, and the serum TSH is elevated. Earlier in the course of this disease, there may be transient hyperthyroidism from excessive release of thyroid hormones from damaged follicles. Other autoimmune diseases, such as Addison disease or pernicious anemia, may also occur in patients with Hashimoto thyroiditis. There is an increased risk for subsequent development of B-cell non-Hodgkin lymphoma. It is important to know that there is multiple immunological mechanisms that may contribute to thyroid cell damage, and this includes first the CD8 cytotoxic T cell mediated killing, secondly is the cytokine mediated cell death, and the other is the antibody dependent cell mediated cytotoxicity. These are microscopic images for the Hashimoto thyroiditis patients. At the upper image, the thyroid parenchyma contains a dense lymphocytic infiltrate with germinal centers, mainly observed at the right of the field. Residual thyroid follicles lined by deeply eosinophilic Hürthle cells also are seen. Hürthle cells are follicular epithelial-derived cells, large, polygonal, and has abundant eosinophilic granular cytoplasm because of loads of mitochondria within them. In addition, we could notice that the colloid within the follicle is scanty or absent. At the lower right image, which is at high power microscopic view of the thyroid with the Hashimoto thyroiditis, demonstrates the pink Hürthle cells at the center and right field. In addition, a lymphoid follicle is at the left, could be observed. Hashimoto thyroiditis initially leads to painless enlargement of the thyroid, followed by progressive atrophy over following years. Aside from surgery, this is the most common cause of hypothyroidism in adults. The other clinical subtype of thyroiditis is called the subacute granulomatous thyroiditis or decurvent thyroiditis. It is much less common than Hashimoto disease and is most common between 30 to 50 years of age, and like other forms of thyroiditis, occurs more frequently in women. This figure is for a patient with granulomatous thyroiditis, also known as decurvent disease. This is an uncommon form of thyroiditis. Begins with diffuse painful thyroid enlargement, which probably follows a viral infection. Microscopically, you need to note the marked acute inflammation along with lymphocytes, macrophages, and dominant giant cells, which is indicated by the diamond shape. In addition, there is destruction on the thyroid follicles. This disease is usually self-limited over weeks to months with transient hyperthyroidism and or hypothyroidism, and affected patients return to euthyroid state. The other clinical subtype of thyroiditis is the subacute lymphocytic thyroiditis. It is a self-limited disease that often occurs after a pregnancy, the postpartum thyroiditis. Typically is painless and is characterized by lymphocytic inflammation in the thyroid. After thyroiditis, I would like to give an overview for other autoimmune thyroid disease, which is called Graves' disease. Graves' disease is the most common cause of endogenous hyperthyroidism and is characterized by a triad of manifestations, and these are thyrotoxicosis, ophthalmopathy with resultant exophthalmos, as well as infiltrative dermopathy, which is called pretibial myxotomy. It is worth to know that glucosaminoglycan deposition and lymphoid infiltrates are responsible for the ophthalmopathy and dermopathy. Graves' disease has a peak incidence between 20 to 40 years, with women being affected up to 7 times more common than men. In addition, it is an autoimmune disorder caused by autoantibodies to the thyroid-stimulating hormone receptor that mimic TSH action and activate TSH receptors on the thyroid epithelial cells. It is important to know that there are multiple autoantibodies are produced in Graves' disease, including the following. First, thyroid-stimulating immunoglobulin. Second is called thyroid growth-stimulating immunoglobulins, and the other is TSH binding inhibitor immunoglobulins. This figure is for patients with Graves' disease. Grossly, there is diffuse symmetric enlargement of the gland and a beefy deep red parenchyma. Microscopically, there is diffuse hyperplastic thyroid in case of Graves' disease, at which the follicles are lined by tall columnar epithelium. In addition, the crowded enlarged epithelial cells project into the lumen of the follicles. These cells actively resorb the colloid in the centers of the follicles. Note the clear vacuoles in the colloid next to the epithelium, where the increased activity of the epithelium to produce increased thyroid hormone, and this resulting in the scalloped appearance of the edges of the colloid. You need to know that the laboratory features of the Graves' disease include elevations in serum T3 and T4, as well as decreased serum TSH. This is a gross appearance of diffusely enlarged thyroid gland and somewhat nodular and weigh more than 30 grams. This patient is euthyroid, but noted increased fullness to the neck. Multinodular goiter represents the most common cause for an enlarged thyroid gland and the most common disease of the thyroid. Both thyroid loops are typically diffusely enlarged, but there may be some asymmetry. We should know that diffuse and multinodular goiters, most often caused by dietary iodine deficiency with impairment of the thyroid hormone synthesis, leads to a compensatory rise in the serum TSH, which drives the hypertrophy and hyperplasia of the thyroid follicular cells and ultimately enlargement of the thyroid gland. The degree of thyroid enlargement is proportional to the level and duration of thyroid hormone deficiency. Goiters can be endemic or sporadic. Endemic goiter occurs in geographic areas where the diet contains little iodine. It is used when goiters are present in more than 10% of the population in a given region, common in mountainous areas. The sporadic goiter occurs less frequently than endemic goiter, and it may be caused by excessive ingestion of substances that interfere with thyroid hormone synthesis. In other instances, goiter may result from inherited enzymatic defects that interfere with the thyroid hormone synthesis. In most cases, however, the cause of sporadic goiter is not apparent. These images is for multinodular goiter. On gross morphology, the coarsely nodular gland contains areas of fibrosis and cystic change. Microscopic view of the specimens taken from a hyperplastic nodule shows an area of compressed residual thyroid parenchyma, especially on the periphery. The hyperplastic follicles contain abundant pink colloid within their lumina. In addition, the follicles are regularly enlarged with flattened epithelium. With time, recurrent episodes of hyperplasia and involution combine to produce a more regular enlargement of the thyroid, termed multinodular goiter. Almost all long-standing diffuse goiters convert into multinodular goiters. Clinical features: the goiter may cause airway obstruction, dysphagia, and compression of large vessels in the neck and upper thorax, so-called superior vena cava syndrome. Moreover, the multinodular goiters typically are hormonally silent, but a minority, about 10% over 10 years, manifest with thyrotoxicosis, with autonomous nodules that produce thyroid hormone independent of TSH stimulation. This condition, known as toxic multinodular goiter or Plummer syndrome. The incidence of malignancy in long-standing multinodular goiters is low, less than 5%, at which the goiters demonstrate sudden change in size or associated symptoms, for example, hoarseness of voice. The next few coming slides is to illustrate the thyroid neoplasm. Most thyroid neoplasms manifest as solitary thyroid nodules, but only 1% of all thyroid nodules are neoplastic. We should know that several clinical criteria provide a clue to the nature of a given thyroid nodule, at which the nodules are more likely to be neoplastic if they are: first, solitary nodules, nodules in extreme ages, very young, less than 20 years, or very old, greater than 70 years individual. Other is the nodules that occur in male or with a history of radiation exposure. And finally is that the nodules that take up less radioactive iodine in imaging study, which is called the cold nodules. Follicular adenomas are the most common benign neoplasms, while papillary carcinoma is the most common malignancy. It is worth to note that although the vast majority of adenomas are non-functional, a small proportion produce thyroid hormones, which is the toxic adenomas, causing clinically apparent thyrotoxicosis. In general, follicular adenomas are not forerunners to carcinomas. However, shared genetic alterations support the possibility that at least a subset of follicular carcinomas arise in pre-existing adenomas. This figure is for follicular adenoma of the thyroid gland. Grossly, there is a solitary wire circumscribed nodule is visible in this gross specimens that is surrounded by a thin white capsule. The microscopic appearance shows well-differentiated follicles resembling those of normal thyroid parenchyma. We should know that follicular adenomas and carcinomas both are composed of well-differentiated follicular epithelial cells. The latter are distinguished by the presence of capsular and/or vascular invasion. This is Hertel cell adenoma. On this high-power view, the tumor is composed of cells with abundant eosinophilic cytoplasm and small regular nuclei. Regarding thyroid malignancy, the most thyroid carcinomas, except medullary carcinomas, are derived from the thyroid follicular epithelium, and the majority are well-differentiated lesions. The major subtypes of thyroid carcinoma are as follows. First, papillary carcinoma, accounting for more than 85% of cases. Secondly is follicular carcinoma, accounts about 5 to 15% of cases. Others are anaplastic carcinoma and medullary carcinoma. The medullary carcinoma arises from the parafollicular C cells rather than follicular epithelium. For the papillary carcinomas, these tumors may occur at any age and associated with the previous exposure to ionizing radiation. This figure is for papillary carcinoma of the thyroid gland. As seen in Figure A, a papillary carcinoma with grossly visible papillary structures are observed. In Figure B, you can notice a well-formed papillae. In addition, in the Figure C, these papillae are lined by cells with characteristic empty-appearing nuclei called the ground glass nuclei, sometimes termed orphan Annie eye nuclei. Figure D, the cells obtained by fine needle aspiration of the papillary carcinoma. The characteristic intranuclear inclusions are visible in some of the aspirated cells, indicated by the red arrows. It is worth to know that the papillary carcinomas are recognized by nuclear features, the ground glass nuclei and the pseudo-inclusions, even in the absence of the papillae. These neoplasms typically metastasize by way of the lymphatics, but the prognosis is excellent. This is another papillary carcinoma of the thyroid. Microscopically, this carcinoma in the left panel has fronds of tissue that form a papillary pattern with papillations lined by cells with the nuclei that appear clear, empty on H&E staining after formalin fixation, and is called the orphan Annie eye nuclei. The hand-drawn illustration of the orphan Annie eye nuclei at number 1, revealing large nuclei cleared out in the center with the powdery chromatin marginated to the periphery, along with the few open-faced nuclei, number 2, and the closed-faced nuclei, number 3. In addition, we need to note another microscopic hallmark of papillary carcinoma, which is the small somoma body seen in the center of the field. At high magnification in the right panel, it is observed as a round laminated concretion. Next is the follicular carcinoma. They are more common in women and manifest at an older age than papillary carcinomas, with a peak incidence between 40 and 60 years of age. It is more frequent in areas with dietary iodine deficiency. This figure shows the follicular carcinoma of the thyroid gland. A few of the glandular luminae contain recognizable colloid. It is important to note that the follicular adenomas and carcinomas both are composed of well-differentiated follicular epithelial cells. The latter are distinguished by presence of capsular and/or vascular invasion. This figure is to demonstrate the capsular invasion in follicular carcinoma in order to distinguish follicular adenomas from follicular carcinomas. As seen in Figure A, the adenomas has a fibrous capsule, usually thin but occasionally more prominent, surrounds the neoplastic follicles, and no capsular invasion is seen, as indicated by the arrows. Compressed normal thyroid parenchyma is usually present external to the capsule, seen at the top of the field. In Figure B, in contrast, follicular carcinomas demonstrate capsular invasion that may be minimal, as in this case. We should know that the follicular carcinoma tend to metastasize through the bloodstream, the hematogenous dissemination, especially to the lungs, bone, and liver. In contrast with papillary carcinomas, regional nodal metastases are uncommon. The other thyroid malignancy is anaplastic carcinomas, which are thought to arise by progression of more differentiated neoplasms. They are highly aggressive, uniformly lethal cancers. The last type of thyroid carcinoma is called the medullary carcinoma. The medullary carcinomas are non-epithelial neoplasms arising from the parafollicular C cells and can occur in either sporadic, about 70% of cases, or familial, about 30%, occurring in the setting of multiple endocrine neoplasia syndrome, type 2A or 2B, or even familial medullary thyroid carcinoma without an associated multiple endocrine neoplasia syndrome. This figure is for the medullary carcinoma of thyroid gland. These tumors typically contain amyloid deposits, which are a characteristic histologic finding. The amyloid is visible here as homogeneous extracellular material derived from calcitonin molecules secreted by the neoplastic cells. Here in this microscopic view, the amyloid stroma of the medullary thyroid carcinoma has been stained with Congo red. It is important to know that the familiar medullary carcinomas are characterized by the presence of multicentric C-cell hyperplasia in surrounding thyroid parenchyma, a feature usually absent in sporadic lesions. Next to be discussed is the parathyroid glands and their disorders. This is a microscopic view of a normal parathyroid gland, at which there are variable numbers of adipocytes, seen here mostly on the left, which are mixed with the small nests of chief cells that secrete parathyroid hormone. In addition, there are typically small nodules of pink oxyphil cells, indicated by diamond shape, whose function is obscure. The parathyroid gland has a rich vascular supply, as in all endocrine tissues, secreting hormonal products directly into the bloodstream. Embryologically, parathyroids are derived from the third and fourth pharyngeal pouches and are present on the posterior aspect of thyroid gland, as superior and inferior pairs. Parathyroid hormone is released inversely to ionize calcium and magnesium levels in the blood. Normally, decreased levels of free calcium stimulate the synthesis and secretion of parathyroid hormone, which has the following effects on its target tissue, especially the kidneys and bones. First, there is an increased renal tubular reabsorption of calcium. Secondly is increased urinary phosphate excretion. The other is increased conversion of vitamin D to its active dihydroxy-4 in the kidney, which in turn augments gastrointestinal calcium absorption, and finally enhance osteoclastic activity. The main parathyroid gland dysfunction is the hyperparathyroidism. Hyperparathyroidism occurs as primary, secondary, and less commonly tertiary hyperparathyroidism. Primary hyperparathyroidism represents an autonomous, spontaneous overproduction of parathyroid hormone, while the latter two conditions typically occur as a secondary phenomena in patients with chronic renal insufficiency. It is important to know that the primary hyperparathyroidism is the most common cause of asymptomatic hypercalcemia. In a majority of cases, primary hyperparathyroidism is caused by a sporadic parathyroid adenoma, and less commonly by parathyroid hyperplasia or carcinoma, which accounts for 10 or 1% respectively. Abnormalities in two genes are commonly associated with parathyroid tumors, and these are the cyclin D1 gene rearrangements, and the other is MEN1 mutations. The parathyroid adenomas are solitary, while hyperplasia typically is a multiglandular process. This figure is for chief cell parathyroid adenoma. In figure A, which is a low power view, a solitary hypercellular adenoma is delineated from the residual normocellular gland on the upper right, at which a rim of normal parathyroid tissue is mixed with the adipose tissue cells. The figure for B, which is for the high power details, shows a minimal variation in nuclear size and occasional follicle formation. Here is the microscopic appearance of parathyroid carcinoma. The parathyroid carcinoma, seen at the medium power in the left panel and higher power in the right panel, shows distinctive bands of fibrous tissue, indicated by star shape, between the nests of carcinoma cells. The nests of neoplastic cells are not very pleomorphic, so invasion and metastasis are the only reliable indicators of malignancy. The high serum parathyroid hormone levels with parathyroid carcinomas, adenomas, and hyperplasia can increase bone osteoclast activity and bone remodeling to produce osteitis fibrosis cystica and brown tumor of the bone. In addition, renal changes include nephrolithiasis and nephrocalcinosis could occur. Moreover, metastatic calcification secondary to hypercalcemia could be seen in stomach, lungs, myocardium, and blood vessels. As I said, secondary hyperparathyroidism is caused by hypercalcemia, most often secondary to renal failure, and the parathyroid glands are hyperplastic. Other endocrine organs that tries to outline in this presentation is the adrenal glands, and I will cover the main disorders affecting the adrenal cortex and medulla. The adrenal glands are paired endocrine organs consisting of cortex and medulla, which differ in their development, structure, and function. This figure is for the microscopic appearance of normal adrenal glands. The normal layers of the adrenal gland are not that distinctive. At the far right is the surrounding adipose tissue, indicated by a square shape. Moving left in the image, next is the fibrous tissue capsule, indicated by star shape. Adjacent to the capsule is the zona glomerulosa, indicated by diamond shape, whose cell produce mineralocorticoids, such as aldosterone. Then comes the zona fasciculata, the black square, in the center of the image, constitutes about 75% of the adrenal cortex, whose cells produce glucocorticoids, mainly cortisol. Next is the zona reticularis, indicated by cross shape, composed of darker and slightly smaller pink cells producing sex steroid hormones. At the far left is the medulla, indicated by yellow circle, composed of chromatin cells, which produces catecholamines. One of the disorders of the adrenal cortex is the adrenocortical hyperfunction. There are three distinctive hyperadrenal clinical syndromes, each caused by abnormal production of one or more of the hormones produced by the three layers of the cortex. And these are Cushing syndrome, characterized by excessive production of cortisol. Secondly is the hyperaldosteronism, caused by an excess of mineralocorticoid. And finally is the adrenogenital or paralyzing syndromes, caused by an excess of androgens. The first adrenocortical hyperfunction is Cushing syndrome. It's also called the hypercortisolism. It is caused by elevated glucocorticoid levels. In clinical practice, the majority of Cushing syndrome cases are the result of administration of exogenous glucocorticoid, and it is an iatrogenic. The remaining are endogenous, and the three most common disorders are indicated in this figure as the following. First, in the upper left image, the primary hypothalamic pituitary diseases associated with hypersecretion of ACTH, also known as Cushing disease, accounts for about 70% of cases of spontaneous endogenous Cushing syndrome. The other, as seen in the lower left image, is the secretion of ectopic ACTH by non-pituitary neoplasms, such as small cell lung cancer in this case, or carcinoids, medullary carcinomas of the thyroid, and pancreatic neuroendocrine tumors. The other is the primary adrenocortical neoplasm, adenoma or carcinoma, and rarely the primary cortical hyperplasia. These are the ACTH-independent Cushing syndrome. Note, in iatrogenic Cushing syndrome, there is a bilateral adrenal atrophy, whereas in endogenous form, there are bilateral adrenal hyperplasia could be seen, except for the functioning adenomas and carcinomas, at which adjacent adrenal cortex and contralateral adrenal gland are atrophic as a result of suppression of the endogenous ACTH by high cortisol levels. This figure is for the comparison of atrophic, normal, and hyperplastic adrenal glands. The pair of adrenals in the center are normal in size, have a well-defined rim of golden cortex and a center of reddish medulla. Those at the top come from a patient with adrenal atrophy with either Edson disease or long-term corticosteroid therapy. The adrenals at the bottom represent bilateral cortical hyperplasia. This could be due to a pituitary adenoma secreting ACTH, Cushing disease, or Cushing syndrome from ectopic ACTH production, or idiopathic adrenal hyperplasia. This is a gross appearance of primary pigmented nodular adenocortical hyperplasia, showing prominent pigmented nodules in the adrenal gland. On histologic examination, the nodules are composed of cells containing lipofuscin pigment, seen in the right part of the field. This figure is for adrenocortical adenoma. Grossly, the adenoma is distinguished from nodular hyperplasia by its solitary circumscribed nature. The functional status of an adrenocortical adenoma cannot be predicted from its gross or microscopic appearance. The right image shows histologic features of an adrenal cortical adenoma. The neoplastic cells are vacuolated because of the presence of intracytoplasmic lipid. There is mild nuclear pleomorphism. In addition, on microscopic examination, the adrenocortical adenomas are composed of cells similar to those encountered in the normal zona fasciculata. By contrast, the carcinomas associated with Cushing syndrome tend to be larger than the adenomas. These tumors are non-encapsulated masses, having all of the anaplastic characteristics of cancer. The signs and symptoms of Cushing syndrome represent an exaggeration of the non-actions of glucocorticoids. The early manifestations of Cushing syndrome include hypertension and weight gain. With time, the more characteristic centripetal redistribution of adipose tissue becomes apparent, as seen in this figure, include central obesity, moon faces, as well as accumulation of fat in the posterior neck and back, and is called the buffalo hump. In addition, cutaneous striae are particularly common in the abdominal area, as seen in this picture. This figure illustrates the signs and symptoms of Cushing's disease. The characteristic centripetal redistribution of adipose tissue is shown here, with resultant truncal obesity, moon faces, as well as accumulation of fat in the posterior neck and back, which is called the buffalo hump. Thinning of the hair, acne, and increased facial hair, which is called hirsutism, are also observed. The skin appears thin, fragile, and easily bruised as a result of loss of collagen. Moreover, cutaneous striae are common in the abdominal area. In addition, there are decreased muscle mass and proximal limb weakness. The bones may develop osteoporosis and susceptible to fractures. Secondary diabetes mellitus and decreased immunity with increased risk for a variety of infections. Others include menstrual abnormalities, psychiatric symptoms such as depression and psychosis. It is important to remember that in pituitary and ectopic Cushing syndrome, ACTH levels are elevated. In contrast, ACTH levels are low in Cushing syndrome secondary to adrenal tumors. The other adrenocortical hyperfunction is the hyperaldosteronism. It is the term for a group of closely related conditions characterized by chronic excess aldosterone secretion. It may be primary or may be secondary to an extra-adrenal cause. Primary hyperaldosteronism refers to autonomous overproduction of aldosterone with resultant suppression of the renin-angiotensin system and decreased plasma renin activity. The main causes of primary hyperaldosteronism are seen in this figure, include bilateral idiopathic hyperaldosteronism, characterized by bilateral nodular hyperplasia of the adrenal glands. It is the most common cause, accounts for about 60% of cases. Second is the adrenocortical neoplasm, either an adrenocortical carcinoma, which is a rare cause, or most commonly aldosterone-producing adenoma, a condition referred to as Cone syndrome. The other rare cause is the familial hyperaldosteronism. Chronic excess of aldosterone secretion could cause potassium moves from bloodstream into the tubule and is excreted. In addition, the sodium is reabsorbed from tubular urine back into bloodstream, resulting in hypertension. In secondary hyperaldosteronism, aldosterone release occurs in response to activation of the renin-angiotensin system, characterized by increased levels of plasma renin, and is encountered in association with the following. First, decreased renal perfusion, such as arteriolar nephrosclerosis and renal artery stenosis, and in conditions of arterial hypovolemia and edema, such as congestive heart failure, cirrhosis, nephrotic syndrome, or even in pregnancy. Clinically, the most important clinical consequence is hypertension. Hypokalemia results from renal potassium wasting and, when present, can cause a variety of neuromuscular manifestations such as weakness, paresthesia, visual disturbances, and frank tetany. Regarding adrenocortical insufficiency, it may be primary hypoadrenalism or secondary hypoadrenalism resulting from ACTH deficiency. Primary adrenocortical insufficiency may be acute, called adrenal crisis, or chronic, termed Addison disease. Causes of acute adrenal insufficiency includes first, sudden withdrawal of long-term corticosteroid therapy. Second cause is the stress in patients with underlying chronic adrenal insufficiency. The other cause is massive adrenal hemorrhage. Occurs in patients maintained on anticoagulant therapy, post-operative patients with DIC, during pregnancy, and in patients suffering from overwhelming sepsis associated with Neisseria meningitis. In the lateral setting, it is known as the Waterhouse-Friderichsen syndrome. This figure is for the Waterhouse-Friderichsen syndrome. Bilateral adrenal hemorrhage in an infant with overwhelming sepsis resulting in acute adrenal insufficiency. At autopsy, the adrenal glands were grossly hemorrhagic and shrunken. In this photomicrograph, little residual cortical architecture is discernible. These adrenals have a black-red to black color from excessive hemorrhage. Infection with Neisseria meningitis can start initially as a mild pharyngitis, but become a fluoride septicemia with hypotension and shock within hours. In the microscopic appearance, there is marked hemorrhagic necrosis of the adrenal cortex that leads to acute adrenal insufficiency. This patient with Waterhouse-Friderichsen syndrome has sepsis with disseminated intravascular coagulopathy and marked purpura involving the skin, as shown here in a child. The time course to development of this complication can be less than a day. Addison disease, the chronic adrenocortical insufficiency, most often is secondary to autoimmune adrenalitis in the Western world, which occurs in the context of autoimmune polyendocrine syndromes, tuberculosis, and infections due to opportunistic pathogens associated with the human immunodeficiency virus, and tumors metastatic to the adrenals from carcinomas of the lung and breast are the other important causes of chronic hypoadrenalism. This figure is for the tuberculous adrenalitis. Shown here is a granuloma indicated by diamond shape with central pink areas of caseous necrosis and surrounding inflammation with lymphocyte epithelioid cells and Langerhans giant cells. Residual adrenal cortex is also seen on the right. This infection proceeds over months to years, and adrenocortical destruction leads to chronic adrenal insufficiency. It is worth to know that the patients typically presented with fatigue, weakness, and gastrointestinal disturbances are common include anorexia, nausea, vomiting, weight loss, and diarrhea. For the primary adrenocortical insufficiency, it is also characterized by high ACTH levels with associated skin pigmentation. The following slides are to discuss the tumors of the adrenal medulla, both neoplasms composed of chromaffin cells called the pheochromocytomas and neuronal neoplasms, including neuroblastomas. Pheochromocytomas are neoplasms composed of chromaffin cells synthesize and release catecholamines, and in some cases, other peptide hormones. They give rise to a surgically correctable form of hypertension. Pheochromocytomas usually subscribe to a convenient rule of tens, and these are 10% are extraadrenal, where they are called paragangliomas, 10% are bilateral, 10% are malignant, and 10% are not associated with hypertension. It is important to know that 25% of individuals with pheochromocytomas and paragangliomas harbor a germline mutation in one of at least 6 known genes, including RET, NF1, VHL, as well as the 3 genes encoding subunits within the succinate dehydrogenase complex, CDHB, CDHC, and CDHD. This figure is for the pheochromocytoma. The tumor is enclosed within an attenuated cortex and demonstrates areas of hemorrhage. The coma-shaped residual adrenal gland is seen in the lower portion. This patient had episodic hypertension. Note the likely sudden rise in blood pressure midway through the operation as the tumor was being manipulated during removal. Here is the microscopic appearance of pheochromocytoma, demonstrating characteristic nests of cells which are polygonal to spindle-shaped chromaffin cells and their supporting cells with the abundant cytoplasm and capillaries in between. In addition, note the nuclei are often pleomorphic. It is not uncommon to find bizarre cells such as the one in the center of this image, even in pheochromocytomas that are benign. The laboratory diagnosis is based on demonstration of increased urinary excretion of free catecholamines and their metabolites, including vinyl-mandelic acid and metanephrines. Next is the neuroblastoma. Neuroblastoma is the most common extracranial solid tumor of the childhood during the first 5 years of life. It may occur anywhere in the sympathetic nervous system, but most common in the abdomen, in adrenal medulla or retroperitoneal sympathetic ganglia. Most neuroblastomas are sporadic, Familial cases also have been described. This neonate had a congenital neuroblastoma arising in the right adrenal gland. This neoplasm, marked by the white arrow, is a regular tan mass with focal hemorrhage and large enough to display the liver to the left of the body. Despite the higher stage seen here, neuroblastomas arising in infancy have a better overall prognosis. Neuroblastoma belongs to small round blue cell tumor, a group of childhood tumors that is characterized by a similar appearance under the microscope. The appearance is that of small, round, primitive cells that stain blue with conventional staining techniques. The small round blue cell tumors include neuroblastoma, rhabdomyosarcoma, non-Hodgkin's lymphoma, and the Ewing's family of tumors. This is the microscopic appearance of adrenal neuroblastoma, which is one of the small round blue cell tumors most typically seen in the pediatric age range. These neoplasms can reach a large size in the retroperitoneum before detection. They often contain areas of necrosis and calcification. Hypertension may be present in some cases. The final topic is the multiple endocrine neoplasia syndromes. Multiple endocrine neoplasia syndromes are a group of inherited diseases caused by proliferative lesions, including hyperplasias, adenomas, and carcinomas of multiple endocrine organs. The arising endocrine tumors have certain distinctive features that are not shared with their sporadic counterparts, and these are: first, they occur at a younger age. They may arise in multiple endocrine organs, either synchronously or metachronously, often are multifocal even in one organ. And finally, these tumors are usually more aggressive and recur in high proportion of cases. The multiple endocrine neoplasia syndromes are of two types. First is the multiple endocrine neoplasia type 1. The multiple endocrine neoplasia type 1 is caused by germline mutations in the MEN1 tumor suppressor gene, which encodes a protein called menin. Organs most commonly involved are the parathyroid, the pancreas, and the pituitary, the three P's letters. In parathyroid, primary hyperparathyroidism accounts in 80 to 95% of patients. The parathyroid abnormalities include hyperplasia and adenomas. The second P is the pancreas. Endocrine tumors of the pancreas are aggressive and have metastatic disease. They are functional, that means secrete hormones, include Zollinger-Ellison syndrome associated with gastrinomas and hypocalcemia associated with insulinomas. They are leading cause of death in multiple endocrine neoplasia type 1. The third P is the pituitary. The most frequent is the prolactin secreting macroadenoma. In some cases, acromegaly could occur. Secondly is the multiple endocrine neoplasia type 2. It comprises two distinct groups of disorders that have unified by activating mutations of the RET proto-oncogene at long arm of chromosome 10, region 1, band 1, subband 2. Multiple endocrine neoplasia type 2 is inherited in an autosomal dominant pattern. The multiple endocrine neoplasia type 2 has two subtypes, and these are the multiple endocrine neoplasia type 2A and multiple endocrine neoplasia type 2B. Organs commonly involved in multiple endocrine neoplasia type 2A include the following. First, thyroid, at which medullary thyroid carcinoma develops in almost all untreated cases, could occur in the first 2 decades of life, commonly are multifocal. The second organ is the adrenal medulla. Pheochromocytoma develops in 50% of patients. Fortunately, 10% are malignant. The other organ is the parathyroid. About 10 to 20% of patients develop parathyroid gland hyperplasia with manifestations of primary hyperparathyroidism. The second subtype is the multiple endocrine neoplasia type 2B. Patients develop medullary thyroid carcinomas, which are usually multifocal and more aggressive than in multiple endocrine neoplasia type 2A, as well as pheochromocytomas. It is worth to know that the multiple endocrine neoplasia type 2B has the following distinctive features, and these are: first, primary hyperparathyroidism does not develop in patients with multiple endocrine neoplasia type 2B, and the other important feature is that extra-endocrine manifestations are characteristic in patients with multiple endocrine neoplasia type 2B. These include ganglioneuromas of mucosal sites as well as morphinoid habitus. These are the main references that are used in this presentation. Thank you.